at 7 o'clock. So without further ado, we'll start our session. So once again, good evening, everyone. Thanks again for joining in and thanks for sending in your cases. The chat is as always open for your comments and suggestions. So without further ado, I think we have the first three cases are from Ankura. And as Dr. Ramya is already here, we'll start off with our first case. Okay, Ramya, over to you.
Yeah. So this child is a third child of consanguineously married couple. First two children being girls. This boy is otherwise well. Didn't have any issues. Perinatal was normal. Then they went to some their local place. After which he had fever for a couple of days. After fever, he started having encephalopathy. He had seizures, a couple of them again. But seizures got controlled very easily only. But after the fever has subsided, he was very, very encephalopathic, not opening his eyes and opening also very for some time and then again going back to sleep. Otherwise, developmentally appropriate, anthropometric, all that is fine. Examination also didn't add any further clues.
Okay. Yeah. So MRI was done into day of illness, Ramya? Any idea?
Yeah, fourth day of illness.
Okay, all right. With that, we'll move on to the MRs. So we have the flares on top, the flare axils and the T2 axils on bottom. And you can appreciate this is a likely incidental lesion out here in the left intraventricular region extending up to the deep white matter. If you see, it is following the CSF signals on both the flares and the CSF and the T2 sequences. But other than those, this focal lesion, which looks benign, there is multifocal abnormalities, especially if you see on the T2 sequences. You can see that the deep brain nuclei, especially the thalamus, demonstrate these focal hyperintensities. The vesta ganglia also more on the left side is demonstrating these hyperintense changes. The right anterior periventricular region, deep frontal white matter also has some focal flare hyperintensity. Coming down to the posterior fossa structures, you can see that the brainstem, possibly the dorsal brainstem, is slightly hyperintense over there in the pons, and especially the last image out here, you can see that the cerebellar white matter also again has these focal hyperintensities out there. Could not appreciate any structural malformations on these sequences. Yeah, so multifocal abnormalities predominantly involving the central regions of the brain, supra and infratemporal, and some areas of the periventricular and deep frontal white matter. And this lesion out here in the left ventricle. Post contrast, there was no enhancement of the cystic lesion or the multifocal abnormalities as we have seen in the T2 and axial sequences. Posterior fossa also could not appreciate any enhancement. The optic nerves I thought were enhancing on both sides. There were bilateral optic neuritis, you can see on the axial images and also in the coronal sequences. Some perineuritis is there on both sides. So with that, I think the first, this was the follow-up. So CSF was normal. I think the viral PCR panel was normal. TMS was normal. And Ramya, you mentioned that there is response to thiamine. Was the question mark or the child is improving on thiamine? Ramya, is there?
Sorry, I didn't unmute. No, so the child started improving. But my main doubt is, what is that lesion there? Is it something to be dealt neurosurgically or how is it?
Okay. So just the multifocal abnormalities, I think the initial thoughts were viral encephalitis, and I thought also demyelination was a possibility given that the optic neuritis also was there.
Yeah.
So I assume that CSF is normal, viral PCR is normal, and as you have told me before that I think antibodies have not been sent.
Yeah.
Okay. The lesion, I think it's an incidental lesion. It's a good paper, but around in 2006, published in 2006 or 2009. And you can appreciate these are non-neoplastic cystic lesions in the brain. They have an algorithmic approach. Our category comes under the supratentorial abnormality. And in supratentorial, you can see as identical to our case out here. These are benign cystic lesions, can be termed as neuroepithelial glioependymal cysts. Usually seen in more adult or later in onset, but our child did not have any calcifications, did not show any restricted diffusion, was thin-walled, did not demonstrate any enhancement. I think we can take it as a simple benign cystic lesion. It can be neuroepithelial glioependymal is what I thought of. Yeah, I think demyelination was other consideration. I thought, given that the child has optic neuritis and multifocal abnormalities predominantly involving the gray matter and also some areas of white matter involvement in the posterior fossa. So these were the diagnostic considerations I thought based on the scan. I'll open the case if anyone has any other suggestions. And thiamine, you say, sorry, I missed that. Child is responding to thiamine or?
No, I think that's an incidental thing.
Okay, fine. But Neelu says could be fasciitis. Does the child? Yeah, I agree. Possible. The child is encephalopathic. That is what I thought might correlate with that. Any neurocutaneous markers? Ramya?
Sorry, any?
I mean, Dr. Neelu has raised the possibility of focal alter signal abnormalities. So any NF1 related changes in the skin?
No, he didn't have that. He didn't have. And is FASI common at this age?
No, I mean, you usually see it later onset.
Little later, right?
Yeah, this is 1 year old, right? Yeah.
Yeah.
And given that the child has encephalopathy, seizures,
I think, yeah, that is a match. This the main thing I had doubt was the cystic lesion, whether we have to do something for that.
Any thoughts from the neurosurgery team? Have they seen the scan?
They have seen, even they felt that is not the cause, and then
Yeah.
they told that they'll deal it at a later date. But they also wanted to know the nature of the lesion from the MRI.
Okay. Yeah, I think it's benign. I'm not sure whether it causes pressure effect later on and causes hydrocephalus or some obstruction to the pathway. We have to evaluate, keep track of that. But otherwise, it does not look like a parasitic, like a hereditary cyst or anything to be concerned about at this moment of time.
Yeah.
Right. If there are no further, and if anyone else wants to comment upon any experience of these, especially given the child's age. Yeah, there is peritonitis, Bulent. I agree. With the multifocal abnormalities, yeah, lot of possibilities of the inflammatory antibodies, MOG. Yeah, you're right.
Okay, sure.
So I think, yeah, it may be better if we can send
definitely.
Yeah. Okay. The next case.
So this child is a 5-month-old female child, second born of non-consanguineous couple. Otherwise, antenatal all good. Till this point, the child didn't have any issues. Perinatally good. The child started having vomitings and dull activity for 2 days, only for 2 days. And then the pediatrician has seen that the AF is bulging. And then, so they have got an NSG done, which was showing hydrocephalus. And then the subsequent scans will come. And then they also notice that the child is having little increased head circumference. Not from the very initial days, but little later they start, probably a month time is what they're telling. Antenatal, I have asked them, though I didn't get any scans to see them myself. They told antenatal, they were told everything is fine.
All right, 5-month-old with acute presentation of vomiting, dull activity with these scans. On top is the flare axials. On bottom again we have the diffusion axials, and we have a SAG, T2 weighted SAG. As you can see, there is a severe hydrocephalus. There's dilatation of all the ventricles. Could not appreciate any edema, but there is no scope for any white matter changes. If you see that the ventricles almost is reaching up to the cortical mantle. On diffusion, could not appreciate any cell-rich substance or debris within the ventricles or in the parenchyma or the extra-axial spaces. On the SAT sequences, you can appreciate it's a long-standing condition given that the corpusculum is stretched and thinned out. There is reduction in the volume of the midbrain structures. You can see the turbulent dephasing of the flow voids across the aqueduct and going up to the foramen magnum. You can see that there's possibly a cystic structure out here, just scalloping the occipital bone, also possibly scalloping the inferior aspect of the vermis. So on these sequences, these were the findings. And on the SWA sequences, there are some remnants of hemocytin deposits in the interventricular regions, predominantly the occipital horns. Some hemosiderin also demonstrated in the posterior fossa CSF spaces. The fourth ventricle and the sag recon, you can see that the lining of the cerebellum has these hemosiderin deposits. Also in the ventral aspect of the midbrain. So possibly some intraventricular hemorrhage perinatally. Was it detected on the antenatal scan, NSG? Ramya?
No. So the after looking at this bleeds only, I had doubt whether.
Okay.
Yeah, you go ahead then.
Yeah,
I'll
got it.
ask.
Got it. Yeah. So post contrast could not appreciate any enhancement, meningeal enhancement. Yeah. So there is a significant tetraventricular hydrocephalus with remnants of hemosiderin in the ventricles and the posterior fossa CSF spaces. I think Ramya wanted to know the different cystic malformations in the brain. As you can see, our child possibly fits into the Blake pouch cyst. They usually are associated with supraventricular hydrocephalus, this turbulent dephasing of the CSF along the aqueduct and the foramen of magnum. The other differentials, though does not fit into our case, Danny Walker malformation, usually torcular is elevated, the vermis is hyperplastic and upward rotated. Arachnoid cyst, again, this is more of a child doesn't fit into an arachnoid cyst. You usually can have hydrocephalus, not typically commonly to have hydrocephalus as seen in other conditions such as Blake pouch cyst. And cisterna magna again is not associated with hydrocephalus. When you're thinking of Blake pouch cyst, this is our case, the image of our case, and this is a representative case from the literature. As you can see, they're known to have hydrocephalus, turbulent dephasing of the CSF spaces, and the cystic space along the intravermian compartment. Looks similar to our case. So yeah, I think we're possibly dealing with a Blake pouch cyst causing supraventricular hydrocephalus or tetraventricular hydrocephalus.
Yeah,
Is what I
even
thought.
that was my impression. But the only thing is, can this bleed block the arachnoid villi and produce a similar picture? Was my main doubt.
Yeah, the bleeds, they're more, I mean, it doesn't correlate with the direct CSF pathway. At least it should have been somewhere, maybe along the aqueduct or the megendry or the Lashka, causing some obstruction there. But the bleeds are more aligning the parenchyma, if you see in the posterior fossa there and the ventricles. Sorry. So I wouldn't, I mean, there is a bleed, but I think the major culprit is the intravermian cystic space, which is causing the hydrocephalus.
Though I can't take from their word, they are telling they're very sure that antenatal scans are good and normal. Will Blake pouch cyst, to my knowledge, will not be missed. At least some amount of megaly should be there, right, in antenatal scans?
Yeah, hydrocephalus should be there. Usually involutes around 18 to 20 weeks. Before that, it may
when
not
the
be there.
Lashka opens.
So yeah, so after 20 weeks, then it should be, I mean, some degree of hydrocephalus or ventriculomegaly should be there.
Should be there, right? Yeah, they are just denying that. So that
but if you
that
see
is
the cyst is actually long-standing because you see the thinning of the bone out there, and there's also pressure effect on the vermis, inferior vermis scalloping out there. So
that is what? That is just cisterna magna itself?
No, that's the cyst. The cisterna magna doesn't cause pressure effect. The Blake pouch cyst or arachnoid cyst, they tend to cause the pressure effect.
Okay.
And the cisterna magna usually doesn't cause hydrocephalus.
So how do in on scan, how do you know that the cyst is communicating? Is it like
cyst with the fourth ventricle, the CSF flow wide goes up to the cyst.
okay.
Intravermian.
Okay.
Sometimes they say that on post contrast, the corpus callosum tena colloidea enters into the superior aspect of the cyst wall. That is used to be a standard, but not now. It is not a hard marker for the Blake pouch cyst, at least as far as I know.
Yeah, actually, I asked radiologists for this particular point whether tela colloidea they can see. They told no. That's why I had little doubt whether it is really that or this.
You can see that over here you can see it's entering into the cyst wall, but usually what they describe is it goes inferiorly and superiorly and medially over there. Okay. But this is at this point, I think it's not a very hard marker to rule out a Blake pouch cyst.
Okay. Sure.
I think the EP shunt is done now.
Yeah, it is done. Due for follow-up.
Okay, sorry, you were asking.
In the previous slide.
Yeah.
The central part in that hydrocephalus in the temporal horn, they are choroid plexus only, right? The other one.
Yeah, they are choroid plexus.
Okay, sure.
Okay. Anyone wants to say anything or suggest anything? No. Okay. All right. I think we all agree with the plague pulse is causing hydrocephalus. So with that, we'll
Thank you.
move on to our next case. Thanks, Samya.
Yeah.
And yeah, Kirti, further over to you. Abhishek, can you make Kirti a panelist? I think she's raised her hand.
I'm seeing how to do that.
Yeah, I got it. No, Dr. Abhishek, not you.
Hello.
There's an IT Abhishek.
Hello, am I audible?
Okay.
Yeah, Kirti, good.
Yes. So this child was referred to us actually for an opinion. Was managed elsewhere. So 12 years old girl, developmentally normal, no previous health issues, had recurrent episodes of fever, headache, and meningeal signs, photophobia, vomitings. So these were separated by around 6 months gap, 6 to 8 months gap. Like first episode was in Feb 2022, then May 23, then June 24. Almost a year apart they were there. And every time she would respond to antibiotics like ceftriaxone. Once acyclovir was given, steroid very low dose once was given, and always she responded within 3 to 4 days. And in the first episode, antibiotics were given for 10 days. Second time only for 6 to 7 days, and third time also only for 6 to 7 days. And if we see the CSF pattern, CSF studies pattern, I think it's there in the next slide. The CSF, if we see the pattern of the CSF in these 3 episodes, initial one was normal with 4 cells and protein of 10. However, in the second CSF, there was a significant cellular count of 270 cells. However, all were lymphocytes, and protein had also elevated. And in the third episodes, there was a further increasing trend of the cellular this thing number of cells in the CSF, and the protein almost remained the same. In the first 2 episodes, PCR was not done. She was just treated symptomatically with antibiotics. And in the third episode, CSF PCR was done. Because they were, and in intercurrent illness, she is absolutely fine. There is no symptom at all. Even systemically, there are no other signs and symptoms of any underlying autoimmune disorder or any other pathology. So, because of this recurrent aseptic meningitis, she was being worked up by rheumatologist also. And hence, certain workup were done like C3, C4, ANA, dsDNA. For underlying immunodeficiency, immunoglobulin levels, and lymphocyte subset assay was also done. Those were normal. ANA had come mildly positive, and anti-Rho had come positive, which can be there in Sjogren syndrome. However, she didn't have any other systemic features of Sjogren syndrome. So, and also the rheumatologist was like, she has improved over these episodes without any steroids or immunomodulation. So it's less likely to be an underlying autoimmune disorder. But I just wanted to discuss if, and we had also done MOG for her. MOG was negative. Serum, NMO, and MOG were negative, and antiphospholipid antibodies were also negative. So just wanted to discuss if there are any imaging clues for an underlying autoimmune or any anatomical defect which could explain the recurrent meningitis.
All right. Thanks, Kirti. I think we have 2 scans. One is in 2023 and one is 24. Is that right?
Yes.
Okay. So first images, I have only film images. Hopefully people can see the images. These are T2 axils. On the axils, I cannot appreciate, at least on these images, any focal abnormalities. No extraaxial collections. Volume seems to be okay for the age. Yeah, on the Sag also, I cannot appreciate any abnormalities. I think this is a diffusion sequence out here panel, and the diffusion also I cannot appreciate any areas of abnormal restricted diffusion. Contrast is slightly hazy out here, but the image quality might not be appropriate. But again, on the contrast sequences, at least on these scans, cannot appreciate any abnormal enhancement or focal lesions. I think this is the follow-up a year or so later. On top is the diffusion, and again on the diffusion cannot appreciate any abnormalities. On the flares, nothing stands out in terms of signal change. T2s, there is some interval volume loss. The sulcation pattern is slightly prominent as compared to the first scan, but other than that, not sure if there is any significant abnormality. Post contrast again, do not appreciate any enhancement. Spinal cord was done. Spinal cord again, we don't have axial sequences, but the SAG's screening of the cord. I thought there was some doubtful area over here in the mid thoracic level, but that we don't have access to corroborate. Might be an artifact. Contrast again could not appreciate any enhancement. So I think in terms of the changes, there is interval mild reduction in the volume of the brain. That can be, I think, medication related to the child was on. Was the child on steroids?
No, never.
Okay.
Never.
Okay.
Mm.
Okay. So
The second MRI was reported as some mild sulcal flare hyperintensities in the frontal and parietal region, without any enhancement. But I was not sure if it
was the child under anesthesia. I mean, at least over here I cannot appreciate.
Okay.
If the child was under anesthesia, sometimes they can have flare hyperintensities due to hyperbaric oxygenation. But at least over here I cannot appreciate any signal changes.
Features of craniopharyngeal canal, persistent craniopharyngeal canal.
Sorry, sir.
To Nihaal, any features of persistent craniopharyngeal canal?
Let's see on the photos.
Because we had a child who had 6 sorts of meningitis and turned out to have persistent craniopharyngeal canal, which was causing the meningitis repeatedly, aseptic meningitis.
Yeah, Raflisha, no, I don't see any persistence there. At least not on these images.
Yes.
I had a question.
Yes, sir.
Yeah, is there, did you check for eosinophils in the seeds?
Eosinophils, no, not particularly, sir. They had just given me the cell count and lymphocytes, and not particularly we have checked for eosinophils. No, sir.
Usually it doesn't give us a recurrent meningitis, but it can come with meningitis, which is quite difficult things caused by these great parasites.
Okay.
Is there any, this is a coastal region?
Sorry, sir. So the PCRs had a few parasites, but not all. So we have not checked particularly for the parasites, actually. No, not for parasites. No, only cryptococcal we had done. Cryptococcal antigen was done in one of these episodes, which was not negative, and TB workup, which was negative, and bacterial and viral panel, which had only 1 or 2 parasites, not Plasmodium and few, but not the rare ones.
No, you just have to do a next time it's CSF, you just do eosinophil staining.
Eosinophils, okay, sir.
Find more than 8% of total cell eosinophils in that.
Okay, sir. Okay, yes. Will it be helpful to repeat CSF in the intercurrent illness? Because we don't know whether it's recurrent or a chronic meningitis. Because every time in the successive CSF, we have seen an increasing trend of cells. There was never a normal CSF documented in between the episodes. So we were thinking, would that be of any use to differentiate it with and whether that would give us a clinical handle, recurrent versus chronic meningitis.
No, I don't think we have an answer. Someone asked for immunoglobulin levels, Kirti.
Yes, yes, immunoglobulin levels were normal.
Yeah, sorry. Yeah.
And even the lymphocyte subset assay was also normal. So these two things, but maybe I think eosinophil count, maybe we should check for the parasites. That is one thing.
No epidermoids, no? Yeah.
No epidermis. No epidermis. Yeah, so Kirti has, unfortunately, imaging wise, I don't think I have
Okay.
any answer, except the volume loss, interval volumes, very mild generalized volume loss.
So at least we do not have any anatomical defect. That is
No,
the thing.
no.
Yeah. Okay. Okay.
Okay.
Okay. Yeah.
Okay.
Thank you.
Thanks, Kirti.
Yeah,
Yeah, Anish, sorry, go ahead.
I've seen one case we published that also for recurrent cysticercal meningitis, but the MRI was abnormal. We had some cysts. So again, that's parasitic. So
Okay, sir.
Okay. So I think we can just start with these tuples next time.
Yes. Yes. Okay, sir. Thank you, sir.
Okay.
Thank you.
Thank
Yeah.
you. Thanks, Kirti.
There's one case we saw, we labeled it as Mollaret's meningitis, which is a term used often when you don't know the reason. And HSV2, low values of HSV2 it lingers in the CSF and causes, that's what the postulation is, but our CSF PCR was negative as well.
Okay.
So
Sir, in
people-
your case, was the HSV positive, sir?
Negative.
Negative. Okay. And any
So-
role of acyclovir or anything for Mollaret?
So we just went by what was written in the literature. So first episode we gave acyclovir with steroid. I think the steroid worked each time.
Okay.
And next time when the PCR was negative, we didn't give it. So 3 episodes over the last 7 years, but we couldn't find a reason. I don't know, Mollaret, is that a diagnosis or that's a diagnosis to be given when you don't know?
Yes, sir. Even I checked the literature. There are case reports of Mollarets, and as you said, HSV DNA they are postulated. However, they have written in 3 to 5 years it is self-resolving.
But it'll be worth doing a CSF in between if the family agrees.
Yes, sir. Yes, sir. Yes. I think that will be useful, sir. Yes.
Hey, okay, Kirti, thanks, Dr. Vivek.
Okay, sir.
Thanks, Kirti.
Thank you, everyone.
All right, we'll be moving to Pune. Nitin, if you're there, or Krishna Priya.
Yes, good evening, sir. Good evening, all. This is a 1 year, 3-month-old girl who had a normal development, a transition, and normal development. Mother had one stillborn at 5 months due to cervical incompetence. Antenatally, this child's there was polyhydramnios and maternal GDM. There was no family history. The baby presented to us at 4 months. So the mother is a physiotherapist, and she has been seeing these cerebral palsy children and infantile spasm children. So as soon as she noticed the 1 or 2 spasms, she immediately brought the child. So the baby did not have any regression. As soon as the baby was brought, an EEG was done. Actually, the first EEG was normal. And 1 or 2 days later, it was an abnormal EEG and ACTH was started. And the first dose itself, the child responded. And the child was started on vigabatrin as well and was spasm free 4 months. Then the baby was on follow-up, and apart from some behavioral issues, there was no seizures or spasms. So after about 10 months, baby had recurrence in the form of asymmetric spasms, right or left shoulder. Spasms were there along with head flexion to the same side. Sometimes it was associated with head drops as well. 1 or 2 upper limb myoclonus we noticed in the videos. So these were happening in clusters, especially when the sleep was disturbed. And other than that, recently the child developed focal motor clonic seizures of the left lower limb, spreading to the other limbs as well. So till now, there is no developmental regression. The baby is doing well, started walking. The baby is talking a little bit, few words. So this is the history. At 4 months, when the child started these spasms, an MRI was done. And now, as the baby has developed multiple seizures, thinking that we can refer the child to a surgeon, we repeated the MRI. Since the first MRI was also showing a structural defect.
Okay. So 2 scans, I think we went
Yeah.
through this. Sorry.
Yes.
All right. So this is the scan at 4 months of age. T2 axles on top and T1 inversion recovery sequences on the bottom. And in the T2 axles, you can appreciate that there is some form of malformation in the bilateral frontal regions, some degree of polymicrogyria in the left frontal lobe, and the gray matter heterotopia extending up from the subcortical regions, so it's almost like a transfrontal heterotopia going up to the pendular margin of the frontal horn of the lateral ventricle. The septum pellucidum also are slightly hypoplastic for a 4-month-old child. Myelination for 4 months is appropriate. The posterior limbs are myelinated. Possibly the sphenium also is slightly starting to myelinate on T2 weighted sequences. On the T1 weighted sequences, the contralateral side, you can appreciate again there is some degree of polymicrogyria and some heterotopia on the right frontal region. Better appreciate again on the coronal sequences, you can appreciate that there is again some degree of polymicrogyria, heterotopia, and again some heterotopia on the left side, left frontal region. On the SAT sequences, you can appreciate that the corpus callosum, especially the anterior mid segments, are hypoplastic. This is abnormal for a 4-month-old. So yeah, so there are malformations around the frontal regions, at the septum pellucidum and the corpus callosum or the commissures are hypoplastic. Myelination is all right for age. Follow-up scan done recently. Again, you can appreciate the frontal malformations, the polymicrogyria, the nodular heterotopia on both sides. Yeah, again, the corpus callosum is hypoplastic. The entire commissure itself is hypoplastic. Possibly the brainstem, especially midbrain, is also showing reduced volume out there. So yeah, these are I think the main findings on the scan. And these are just examples of gray matter heterotopias. They can range from transmetal to periventricular region. I think Anisha has pointed out for orbits. Orbits were normal. Anish, I don't have the images. Orbits was normal. Olfactory apparatus was normal. Yeah, so heterotopia, polymicrogyria, usually the heterotopias, in particular, can have some mutation abnormalities, but they are known to have caused by vascular disruption, especially if they are asymmetrical and focal or segmental, as we have seen in our case. Then I think the child was referred for whole exome and mitochondrial genome sequencing. Yeah, Krishna, over to you.
Yes, sir. And VOUS was detected NBEA. But it was not very matching. Parental testing was done, and father is a carrier. So we were wondering if the features are suggestive of any other gene. Should we repeat the analysis? Will be worth it.
Okay, I think you have a second gene too.
Second gene was also detected, SETD2, but it is not at all matching. It is a genetic epilepsy with the developmental delay.
Okay. So at least the published images have some degree of hypoplasia, but no malformation has been published. So imaging wise also it's not a match, complete match. So the question is, I think one was for surgery. Is that the first question?
Yes, actually the imaging was done with surgery in mind, but if the lesions are so extensive.
Good evening, everyone. Dr. Kavita here. So actually, the first MRI was reported as schizencephaly on the right side and with the bilateral frontal cortical dysplasia, more of tachycardia, they had said. That was done at 4 months. and with that transmantle sign and everything.
Yep.
So because we thought that if there is a schizencephaly, and because now the baby was having left focal clonic seizures as well, of course the spasms were more localized toward the right side. So I think there is very poor localization, or lateralization rather. So I just wanted to discuss with the other panelists as well, like what will be their take. The child is now responded initially to ACTH and vigabatrin, and as soon as we started tapering vigabatrin, the child has relapsed, and now we had continued low dose steroids because we were just planning that after the next MRI we'll decide what has to be done, because he responded so dramatically to steroids and the development was progressing very well. So what should be the next step? The child is clearly not amenable for surgery because seizures are multifocal, the EEG is multifocal, as well as there are multifocal abnormalities on the MRI. So what would be the best next step? Maybe Dr. Udani sir or whoever has experience with these kids can maybe give their opinion.
Well, I mean, this is a difficult. Resective surgery is obviously very difficult. We have thought about diet.
So diet we are now planning to add. What I was wondering was, because the this thing diet is also very less likely to work with such extensive this thing. Is corpus callosotomy a good idea, and that too so early?
You have drop attacks. How old is it?
So the child is continuously having now only drop attack, but not falling. She's just having head flexion, flexor spasms, I would say. Not those atonic kind of attacks yet.
The data of corpus callosotomy on spasms is not very good because there seems to be propagation to the brainstem supportive structures. So
So your voice is not very clear. So in your experience, you said with the spasms, it's not very good.
Not very good.
Okay.
No, but for drop attacks, tonic drop attacks or atonic drop attacks, it's very good. Spasms are nothing better.
Because she will clearly go into again bad encephalopathy, epileptic encephalopathy. The EEG has already started worsening again. So I just wanted to know the experience of others. Yeah.
You can give steroids once a month.
Sorry, I'm not able to hear clearly. The steroids, you said?
So did you mean pulse steroids?
Monthly steroids.
Monthly steroids.
Okay.
Yes.
Okay, sir. Okay. Vigabatrin is already going on. And her EEG after ACTH and vigabatrin was quite good, and that's why we started tapering after 6 months this vigabatrin. And as soon as we tapered, she started getting again. So I'm planning to again go back to the previous dose. So the only thing is, with such extensive, we just wanted to be sure that there is not much possibility of a surgical option. No, clobazam we have not yet tried. So what is the other panelists' experience? What may work the best? I mean, ketogenic diet most likely may not be, though I'm going to start it. Should we give vigabatrin for longer? And as we give sirolimus and all for the tuberous sclerosis, is there any role for giving here? Of course, there is no mTOR pathway related problem, but in some dysplasias, it's known to work as a non-specific mTOR inhibitor. What is the experience of the panelists regarding that? Anybody for the dysplasias, these kind of tachycardias? Yes, sir.
No, Vivek here. So
Yeah.
one was about the diagnosis. So set D2 is important. You cannot negate it because it is a deletion, So it's very important, because if there is a deletion, there is a problem. So even though often MedGenome puts it on the second page, and when you look through it, I just look through it. It's very important for cortical development, SET-D2 gene. So maybe people have not reported it, but it might be important, especially with what you saw. There is a 5 base pair deletion leading to, and that's very important. So in the
We'll do
hierarchy
the
of
parental studies for that because
right.
on matching it was not like I think only 30% reverse phenotype.
See, because it is autosomal dominant, it could still be a mosaic. So father or mother might have it still, some amount. So you cannot negate it because it's autosomal dominant. So there is a deletion, which is very important to keep in mind. So that is for the diagnosis. And for the treatment, you just have the first 2 years of her life to save her from future agony, right?
That's what.
So that's why you are confused. What can be done? So now for the next 10 months to save her from, because after that there is nothing left.
Exactly.
Right?
Yeah.
So the options are, as sir said, so is there drops or is it spasms? Do we know?
They are spasms. They are spasms because the initial spasms were more of right-sided, and now she's just having these head drops, which are having a like delta complex on the EEG, which is looking more like a spasm rather than a, because in drop attacks will usually get polyspike wave first.
Right. So with the EMG deltoid, it might help further because that might still not be, we cannot be sure with those deltas whether it is
only on the head.
drop.
There is nothing on the limbs also. So we can maybe put the EMG next time on the neck and see.
Right.
We usually put it on the deltoid, yeah.
So as for medicines, what I have seen last, like just we all try everything. So as sir said, we have to save this 1 year, so we can give monthly pulse of 3 days of methylpred, or we give another course of 6 weeks ACTH and then give weekly ACTH. That's one option, weekly once. After it, put in remission and then keep on maintenance therapy. Those are the steroid options. Then somehow clobazam, especially in the focal, onset spasms, sometimes it works, and Fycompa somehow is appearing to work. I don't know why. Infantile spasms, it somehow helps in some of the patients, especially the genetic ones. So these are sort of options where you can pass 4-5 months to save her cognition. And if after that it becomes really drops, one can think of calostomy. Because surgery still shouldn't be, because one has to be sure, we know her IQ will never be normal. With calostomy, you will never achieve normal IQ. So the only thing is a spasm, it does work. It's not that it doesn't work. Drops, it is much better. So that still is an option. But if you can pass 4-5 months, then maybe, because then it might localize to one place with steroids, then you might be braver. So that's what I feel. So steroid pulse, just sir said. And along with that, Fycompa and clobazam, maybe that might help.
Sure.
And then think of calostomy later. 6 months time.
Okay. Thank you very much. Any other opinions?
Jayan says topiramate worked well for his case after steroids and rigabatin.
Okay, fine. Sure. Thank you very much.
Thank you.
Thanks.
All right, from Pune to Delhi, Dr. Sayani, if you're there, over to you.
Yeah. So this is a 15-month-old boy who is symptomatic since last 2 months. So initially he was premorbidly normal. Now he has had a history of trivial trauma around 2 months back. Followed by that, he developed this progressive motor weakness, which started with the left lower limb. However, it over the next 1.5 to 2 months, it gradually increased, and particularly in the last 20 days when he presented to us. So there was also history of intermittent urinary retention and constipation. And the child had developed, so initially there was no fever, but he has developed this new onset fever since last 5 days prior to presenting to us. And on examination, the child had this flaccid quadriparesis. Lower limbs power was 1/5, upper limb around 2/5. DTRs were absent and plantar was mute. And on the spine examination, there was a dermal pit there was no discharge. It didn't look like a sinus. And there were also some overlying skin changes, looking like some cutaneous markers of maybe underlying spiral dysraphism. So we can have a look at the MRI.
All right. I don't think the complete brain was done, no?
No, this much, yeah.
Okay. All right. So I think that's fine. They just screened the brain. I have only T2s and post-contrast T1 sequences. On the T2s, there is some volume loss, some ventriculomegaly, and supratentorally, maybe some periventricular white matter changes along the posterior aspect. But the main findings, what we appreciate, is on the posterior foci, especially in the medulla and the cervicomedullary junction. You can appreciate some edematous inflammatory changes, hyperintensity changes on the T2 sequence on the axils out there. On the post-contrast T1, no abnormal enhancement, no focal lesions. Even the medulla, which demonstrated hyperintensity changes, does not demonstrate any enhancement. The main findings, though, are in the spinal cord. There is a long segment cord changes from the lower aspect of the medulla cervicomedullary junction going up to the lumbosacral region. So these are the T2-weighted sequences. The cord is expanded, especially in the thoracic and the lumbar level. I think this is the fat side T1 and a normal T1. The LS spine and the thoracic spine does not demonstrate any signals in terms of hyperintensities, fat signals, or hemorrhages within the spinal cord. The cystic changes which you've seen on the T2-weighted sequences demonstrate expected hypointense changes on the T1-weighted sequences. I have the ADC sequences out here. On the ADC, there is no reversal or no signal drop suggestive of some form of, no abnormality on the ADC sequence in terms of restricted diffusion. Post-contrast, again, is the main finding. You can appreciate there is extensive cord myelopathy with these almost peripheral enhancing areas, predominantly more affecting the thoracic and the lumbar spine. Under the axial sequences, you can appreciate is peripheral enhancement of the almost the entire extent of the spinal cord. In terms of the vertebrae, I could not appreciate any vertebral bony abnormalities. In terms of sinuses, I couldn't trace a sinus or the dermal sinus on these images. A DICOM was sent, and in that also I could not appreciate any dermal sinus tracking to the subcutaneous cutaneous region. So I think the diagnostic consideration, I think dealing with an infection-related disorder. When I saw this case, this case was previously discussed, though it was a younger child. This child also had extensive spinal cord involvement and also brain meningeal enhancement and meningitis. This turned out to be dysteria, and our case looks somewhat similar to this case. So I would consider, I think, infection-related disorders and the follow-up. Sorry.
Yeah, so sepsis screen was positive for this child, and on CSF, there was some pus-like material which was coming, so we could not even send for analysis because it was just the spinal needle was getting blocked. So my question is that there are some cystic structures in the lower down. So is this some kind of a
like the question was dermoid, yeah. So that's why
on
T1s there was no signal. I mean, there's some degree of fat signal or signal which is not there in our case.
Okay.
Dermoid sometimes can show restricted diffusion, which was not seen on the ADC signals.
Okay.
I was thinking that it is primarily an infective inflammatory pathology going from top to bottom, causing these changes in the spinal cord.
But even below the corners, because of the infection only, primary.
Yes. I mean, that's what I thought.
Okay, so that was my doubt. So there was just a pit. There was no history of any discharge. So we were also doubting about, because I also could not see any connection between the skin and the, not like a sinus.
So this is a long-standing infection, no? 2 months. 2 months.
2 months, yeah. Weakness is there, but fever is only since last 5 days. That is that is one.
Okay.
Clinically, it should have been there from the beginning.
Okay.
If the motor weakness
I was thinking any chronic infection, TB or something.
Okay.
I was just wondering whether we should keep a kind of a mark on the dermal foot. Is it above the sacral?
Usually we can try injecting from the pit. I mean, put a mark. Usually a fat side.
We can put a mark and do the thin cuts.
Yeah.
To that area.
This is the Fiesta
axial, and because it is a small dermal sinus, this could well be some infection.
Yeah.
Okay.
So usually when we have a suspected double sinus, we do the CIS or PSS sequence around 1 millimeter cut 3D.
Okay. Okay.
A mark is kept if the child is corporate. Otherwise, it's still the 1 millimeter cut should be able to trace any sinus. But that's the main concern for the ICU team, because they usually say that it's a very red dot area for a source of infection there. So they're very particular on that.
Is it a cleft or pit or whatever? Is it above the cleft or below the cleft? Sacral cleft?
No, no, sir. It is above, sir. Like it is around in the lower lumbar region, sir.
Yeah, so that is usually significant, and the ones which are less significant are the ones below the cleft.
Yeah. So there is some overlying skin, like the skin is little, like just some hyperpigment, not like a hemangioma or something, but maybe a discolored, like that is since birth. So I was just mainly wondering about the cystic structures. Yeah.
So, I would attribute it entirely to the infective.
Okay. Yeah.
From
Okay.
top to bottom.
Okay.
But I think the source of infection needs to be evaluated closely.
Yeah. Okay.
So you can ask them to do a Fiesta or C sequence, 1 millimeter 3D at the level of the suspected clinical, outwardly project sinus at that level.
Okay. Sure. Thank you so much.
All right. Okay, so this case was from Dr. Prerna. You can maybe check with her what the treatments and stuff. Not sure what is the protocol.
Actually, we started like on broad spectrum, this ceftriaxone and this thing. Miro and Vanco. Ceftriaxone, he didn't respond. He was still having fever. So now the fever has subsided after 4 days.
Okay, then, yeah, so I think that's the next step. Look for the sinus on the scan. Dermal sinus. Okay, if there are any, yeah, thanks, Annie. If any other further comments are there, please put it in the chat. We'll move on to our next case. All right, Apura, if you're there, over to you.
Yes. So this child is a 4-year-old male child born of a third-degree consanguineous marriage. The child presented with global developmental delay at 4 years of age. The child had cognitive more than motor issues. The child was walking independently, but cognitively there was catch-up in the motor development, but cognitively was still like a 2.5, 3-year-old. Moderate intellectual disability. Primary microcephaly. Head circumference was 46. Short stature was there, and central hypotonia. Otherwise, in examination, there was no other specific handle.
All right.
Probable some dysmorphism, but
okay. I think Dr. Srikanth shared some videos. Not sure what it is. For the radiologist, anything abnormal in the gait, or is it?
probably mild ataxia, but not very consistent. Like
Okay, all right. Okay, with that, I think we have the MR done at 4 years of age. T2 axials out here. As you can see, the brain is not myelinated for age. There is hypomyelinating pattern demonstrated in the supratentorial and the infratemporal brain parenchyma. The additional findings which are helpful, I think, are in the deep brain nuclear structures, especially the globus pallidus and the ventrolateral thalami. The cerebral peduncles demonstrated T2 hypointensities. Again, the brainstem fibers are not myelinated; they are still hyperintense. Cerebellar white matter is again hyperintense, but still there's a hypomyelinating pattern also in the infratentorial compartment. The dorsal striatum is slightly hyperintense than what we normally expect. So on the T2 sequences, we have a hypomyelinating pattern with additional changes in the deep brain nuclei and the cerebral peduncles. On the T1 sequences, I think there was some motion there, but you can appreciate again corresponding changes on the deep brain nuclei. We have T1 hyperintensities, especially in the global pallidi. And on the SAT sequences, we have diffuse thinning of the corpus callosum, which is an added finding to the hypomyelinating pattern. On the SWA sequences, there is increased mineralization or blooming on the SWA in the globus pallidus and the cerebral peduncles, which correspond with the T1 hyperintensities and the T2 hypointensities. And as Dr. Udani has put it, this is just a algorithmic approach to the paper, I think, published last decade by, I think, Van der Lapp and Steenweg. And you can appreciate these pattern fits into the first image out here, hypomyelination with hypointensity of the globus pallidi. Think of leukocytosis. The other patterns slightly different to our case, but again, if there are dark thalami with hyperintense changes, inhomogeneous hyperintense changes, think of gangliosidosis. And more diffuse pattern can be seen in Pelizaeus-Mosbacher disease without the deep brain nuclear involvement. Atrophic changes can be seen in HABC and Tourette syndrome. So RTS again fits into the first image out here in terms of leukocytosis. This is a paper published, I think, by the Pickens and the Great Ormond Street group. They have good pattern recognition approach. Again, hypomyelination with basal ganglia abnormalities, global pallidi abnormalities, think of leukocytosis and ocular interdigital dysplasia. On genetics, Apurva.
Report, it showed both the genes. One was fucosidosis and one was Niemann-Pick type B, but the MRI is more suggestive of fucosidosis.
Yeah, so we have the imaging match at least in terms of fucosidosis. I just wanted to ask the clinicians if there's a pathogenic variant, what is the significance of a likely pathogenic variant? Dr. Shiji, no resources.
See, this is how the geneticists, can you hear me?
Yeah, Dr.
Geneticists reported. We have to go one by the clinical match and also by the report where there is hierarchy of pathogenicity. Like here there is a deletion, so leads to DL deletion, which leads to P is a protein. Where the cysteine valine, there is a frame shift, FS termination. So there is the protein stops. So it's a small protein. So that's very important. Much more than a missense mutation, which is just one to the other one. So one is swapped to the other one. So this is more important. So they will give the report, but we have to go by the clinical match and also by the severity and what is there, And then this is very interesting. People don't often see. So P is pathogenic, and if it was B, it was benign. Now, when you say VS is very strong match. Okay, VS is very strong match. M is moderate. Okay, and P is probably strong. While here it is up to S. So PVS1 is very important. When they write VS1, that means it's very important, very strong match. So this is how you go.
So yeah, I think we're dealing with a classical case of leukocytosis, at least on imaging, and clinically also, I think, as Apurva has mentioned, matches. So we just wanted to show the case and discuss the genetic report. So if there are no further comments, any treatment for these children? Do they? What is the prognosis? Apurva or anyone else for non-radiologists? For radiologists, sorry. Okay. Okay. Dr. Shivalakshmi says same variant in SMPD1 reported as pathogenic by CDFT. Levenar. Okay, I'm not sure what. Linvar. Okay. Clinical variant. Okay. Sheila says there's no treatment, unfortunately. So. All right. So yeah, we just wanted to show that case, and with that, another case from Vijayawada. Apurva, what
Yes.
are you?
So 1 year-old male child, a boy born of a non-consanguineous marriage. This child presented with history of global developmental delay. Motor was much more affected than cognitive. So at 1 year, he was just sitting with support, and cognitively he could recognize mother, and he had some mirror play, but that too was affected. But motor was significantly affected. Also, the child had generalized seizure onset at 6 months of age. Those were fever triggered, and then there were some non-febrile seizures also, brief episodes. On examination, yeah.
Yeah, sorry, go ahead.
Yeah. So on examination, the child had increased tone of all the four limbs. Like the child was almost rigid and had increased tone of the limbs.
Okay. Okay, I'm not sure what the video demonstrates, but child appears to have a large head, or head circumference, any area?
No, not mentioned. Not.
Okay. Fine. So these are the MR images. On top here, the diffusion, and then we have the T2 sequences. Another classic case, which we just wanted to show you. Diffusion could not appreciate, there's no areas of restricted diffusion, but on the T2 sequences, you can see a confluent abnormalities with the anterior to posterior gradient, persistent cavum septum pellucidum out there. There is also involvement of the dorsal striatum, the putamen on both sides, some degree of volume loss, and some changes along the brainstem tracts. The dentate nuclei again slightly hyperintense. There is some cerebellar atrophy. And on the flare sequences, you can appreciate the white matter again, some areas of rarefaction, particularly the subcortical regions and the frontal lobes out there. Again, the anterior to posterior gradient, the deep nuclear involvement, brainstem involvement, no mineralization or hemorrhage on the SWA sequences. So yeah, these are the findings on the MR. Yeah, on the T1 variant sequences, we didn't do a contrast. Those contrast is to be helpful in diagnosis. There are some T1 hyperintense areas in the periventricular regions. Yeah, so again, you can appreciate the anterior to posterior gradient on the SAT sequences. So if you're going in terms of approach, leukodystrophies with anterior predominance, we think of Alexander disease as the prototypical example. The other examples are MLCs, frontal leukodystrophies, and sometimes interferonopathies can also demonstrate these anterior to posterior gradient abnormalities. I think in our case, we're dealing with Alexander's disease. These are the common findings which you see in Alexander's disease: anterior to posterior gradient, confluent white matter abnormalities, deep brain nuclear abnormalities, particularly the dorsal striatal abnormalities. The fornix can be optic nerves can be thickened, and on post contrast, you have this periventricular garland type enhancement pattern on the T1 weighted post contrast sequences. Brainstem and posterior fossa abnormalities can also be demonstrated in Alexander disease. And yeah, on genetics, I think we've got a likely pathogenic match for Alexander disease.
The Alexander's disease is a pathogenic variant.
Okay, if anyone wants to add anything about the images, clinical features, or in general Alexander's disease.
Yeah, just a clinical point. Quite a few of these Alexander disease presenting with febrile lesions. Initially, you will not have many other findings which you maybe slightly larger head, especially slightly later ones. Have you seen that?
Sorry, Dr. Rani, I couldn't hear you clearly.
What I meant is febrile changes sometimes are a presenting feature.
Okay. Dr. X says the initial doesn't. So as per my understanding, febrile seizures is not a typical finding, or is that typical? Sorry.
Yeah, I'm sure we've seen quite a few of these
Okay.
presenting as febrile.
Febrile seizures. Okay, all right. Is that also seen in Vandernaps? I mean, the vanishing white matter, sorry. Another clue for local dystrophy with...
Febrile. No, you don't have. These
Okay.
are, but they're not specifically febrile. These are patients who actually present slightly large heads and febrile seizures.
Okay.
And then some reason the MRI is done, and you actually see every time in the back that will be suspected. This case, of course, the audience will
Got it. Thank you. All right. Sheila says vanishing white matter usually has stick to walking precipitation by febrile illness or trauma. Yeah. Thanks, Sheila. Just when, yeah, febrile illness was the clue. All right. Yeah, we just wanted to show another case which was locked up. It's the case of Alzheimer's. Okay. Razi, over to you. You there?
Yes, sir. 9 months old boy presented with history of moderate grade fever, which was intermittent since 7 days. On day 2 of illness, child had seizures and encephalopathy was there for last 5 days, and history of decreased urine output since 1 day prior to admission. In ER, in view of bradypnea and poor GCS, child was intubated and CT was done and was shifted to PICU for further management. He was afebrile. SpO2 was 98% on bag and mask, bag and tube ventilation. Heart rate was 90 per minute, and blood pressures were 86/50, and peripheries were warm and pulses were felt. On auscultation, chest air entry were bilaterally equal. Heart sounds were normal, and there were no murmurs. Abdomen was soft, no organomegaly. On neurological examination, child DCS was even VT and M1. Pupils were bilateral 3 mm and sluggishly reacting to light.
Anything on the CT, Razi? I don't have the images.
Yes, sir. Initial CT.
Okay, that's fine. That's fine.
Yeah.
That's fine. I think then workup was done after the scan or before the scan?
Workup. Meanwhile, we have sent for investigations and we have shifted the child for CT.
Okay, so after that, I think this was a
Yeah. Child hemoglobin was 11 and WBC 18,000, and platelets there was thrombocytopenia 42,000, and serum sodium was 175, and potassium was 3.6, and chloride was 213. And child was in AKI, creatinine was 2.5, and blood urea was 146. And transaminitis was there with hypoalbuminemia, and there was mild derangement in coagulation as well. With dengue, basic investigations for infective workup was also sent, which were negative. And ultrasound abdomen was showing mild ascites, and CV showed fungal hyphae, and urine culture was sent, which growed Candida tropicalis.
okay.
So and MRI brain was done after 1 day of admission again.
Clinically, at this point, any handle? I mean, what was the infection or?
Due to hypernatremic dehydration, a possibility of CSVT was considered during this point of time.
Okay, all right. Okay, so we have the MR diffusion and ADC sequences. You can appreciate there are some confluent areas of restricted diffusion, predominantly in the central regions involving the capsular white matter, the globus pallidi, the thalami. Some areas of subcortical cortical regions in the temporal occipital regions. You also see in the frontal and parietal lobes out here. The cortex is slightly hyperintense on the diffusion various sequences with reversal on the ADC sequences. Hippocampi also demonstrate restricted diffusion. There are some brainstem edematous changes. The vermis also was slightly bright on the diffusion and with low signals on the ADC sequences, which I think corpus callosum also demonstrated areas of restricted diffusion. I think we're dealing with primarily a cytotoxic brain injury to suprainfratemporal compartments. On the T2-weighted sequences, again, you can appreciate the edematous changes, the cortex is edematous, the white matter changes as we have seen on the diffusion scans. The other areas of the deep nucleus, such as the dorsal striatum, also demonstrate some areas of T2 hyperintensities. And cerebellum is also edematous, the replacement of the sulfur pattern out there. T1 non-contrast sequences of SAG out here on the SAG, you can appreciate there is thrombosis of the suprachiasmatic sinus. And if you look closely at the pituitary gland, the T1 bright spot is not visualized on the pituitary posterior pituitary on the T1 non-contrast sequences. Possibly there is some hypoplasia of the brainstem structures, pons, especially the pons. On the SWS sequences, there was some hemorrhage in the frontal horn on the right side and along the corothalamic groove. As you can see, we have seen on the T1 variant sequences, thrombosis of the suprachiasmatic sinus and some cortical veins also demonstrated areas of blooming first or thrombosis. The history, I think these are some of our case series which had hyponatremia. So children with hyponatremic dehydration, we tend to find these areas, extensive areas of diffusion abnormalities involving the bilateral hemispheres, the deep, the gray and white matter structures, but predominantly the white matter structures, especially the pyramidal tract. The T1 bright spot is another finding which we have commonly seen with children with hyponatremia. The bright spot is not visualized, and these children can tend to have intraventricular hemorrhage, parenchymal hemorrhage, and dural sinus thrombosis, as in our case. The other consideration we thought was a toxic leukoencephalopathy, given that the child had transaminitis, possibly have an acute hyperammonemic or hepatic encephalopathy, but they usually have more predominant involvement of the cortical regions rather than the central white matter structures. So the other possibilities were I think infection or immune related disorders, but primarily I think we thought we are dealing with hyponatremia related toxicity related changes. Yeah, these were the considerations. With that, I'll open the case. If anyone has similar experiences with hyponatremic dehydration, MR images, thrombosis of the dural sinuses, cortical veins. Question for malaria workup from Manish. Razi?
Yeah, smear for MP was negative, sir.
Okay.
Hello, Nihaal. I'm Bulent.
Hi, Bulent. Yeah, Bulent.
Hi. Hi, everyone. Thanks. It's a great case. Yeah, I have, two different cases. One was, presented with, again, with a significant amount of sodium. It was very highly elevated, and the patient arrived with, seizure and, encephalopathy. And there was, peculiar imaging findings like, involvement in the diffusion with images. There was involvement of, again, bilateral internal capsules, especially posterior limb of internal capsules, and also optic radiations, like, almost, similar to case that you are showing here. And there was another case that, in your case, you have, both, superior sagittal sinus thrombosis and also this, diffusion T2 changes. But another case that I have, presented with, again, with hypernatremia, and there was thrombosis of the superior sagittal sinus. It's common in neonates, but sometimes you see also in children if there is a severe, dehydration, and also the supporting findings that you show, there is no increasing T1 hyperintensity of the neurohypophysis, probably due to, secretion of the ADH, to just compensate the patient's dehydration. It's I think classic case.
Yeah. Thanks, Bulent. All right. Yeah. So you just wanted to highlight the possibilities of toxic hyponatremia related changes. In our case, the MR imaging findings, at least all of them, match with the condition of hyponatremic dehydration. So look for cytotoxic edema predominantly in the central regions of the brain, especially the optic radiations, as Bulent has highlighted. Look for the posterior pituitary gland. It is the T1 bright spot is usually absent, and also look for the areas of hemorrhage or thrombosis. All right. Okay. If there are no comments, we'll move on to our next case. Dr. Vivek, over to you.
Yeah. So this child I haven't met. I only met father yesterday. He came for an opinion with all the reports. So I haven't clinically seen the patient. So he's admitted in our only government children's hospital. So, but I thought because it's a meeting today, so try to push in this case because MRI appeared to be interesting and just for the differential to help the family. So this is a well child who was normal before, and now he's 6 month age, and only for last 1 month he has been unwell, and he had acute onset febrile illness, during which within a day he developed multiple left-sided seizures, which actually continued for the next 4 weeks, and for the last 7 days only he has been seizure free. There will be gap of few days and they will start. It was more like the videos father showed was more like EPC, epilepsy partialis continua, but with medications which have been given, the anti-seizure medication, they are not happening now. And the child has started to feed and tract, even though there is left paucity of movements and left side dystonic posturing as well sometimes. His fever has continued for the last 1 month. So there's never been a day when he didn't have a fever. So that is the main concern, that the fever has not responded to the treatment with IV antibiotics. He's on meropenem, and so he's on good antibiotics. So his initial blood test had shown a high CRP. His first CSF at the time of illness had shown mostly neutrophilic response with a low sugar and slightly high protein. So when he came to me yesterday, and his CT was done in the hospital from where he was referred to the government hospital in Jaipur. He was seen in Gwalior, where he was initially treated. So there a CT was done. Unfortunately, I don't have the images. That showed multiple hypodensities in both thalamus, left cortex, and midbrain. And when I saw him yesterday, I only had the MRI images which were done in Jaipur just a week back, which we are going to show now. So I had some confusion about the differentials which could we think of. They're not the best of the images, I still feel, but if we could help them with what we see.
Okay. All right. So again, we have diffusion and ADC here. The initial sequences, I can appreciate there is some subdural collections, I think, better appreciated on the T2s and flares. Probably could see some areas of diffusion restriction with corresponding signal changes on the ADC. You can appreciate the cortex subcortical regions, especially in the frontal lobes, the perisylvan regions out there. The spinning of the corpus callosum demonstrated restricted diffusion. The sequences had some motion artifact, but overall, like maybe some areas of cytotoxic edema and some focal abnormalities on the diffusion-based sequences. The T2
this is 4 weeks. This is 4 weeks into the illness, the MRI. Yeah.
Got it. All right. So on T2 sequences, again, some volume loss, subdural collections on both sides, both convexities, and you have these confluent and multifocal abnormalities in terms of hyperintensities involving the white matter structures, the gray matter structures, the focal abnormalities in the deep gray nuclei, also in the midbrain out there, possibly in the medulla also on the T2 sequences, subdural collections again on the flares. The SWS sequences demonstrated microhemorrhagic foci. In the, again, you can appreciate in the frontal lobes, the deep gray nuclear structures, the perisylvan regions, and also the brainstem fractures with some areas of subdural hemorrhages, especially in the left retrocerebellar region, and some areas of lining of hemosiderin along the anterior convexities on both sides. Post contrast, I could appreciate some degree of enhancement of the pachymeninges. Some of the cortical veins demonstrated some septation, demonstrated some enhancement, some septations, possibly in the subdural collections out there in the frontal lobes. The areas in the deep gray nucleus demonstrated predominantly peripheral enhancement. You can appreciate in the centromedian thalamic nuclei out there. And also in the midbrain, you have this punctate foci of enhancement in the midbrain. Yeah, other than those, and the MRV did not demonstrate any thrombosis. The right-sided veins, which sinuses on the posterior fossa are hyperplastic. That's the normal variant. So yeah, I think some degree of volume loss, subdural collections, these punctate for the focal abnormalities in the deep gray nuclei, some pachymeningeal enhancement are predominantly seen on these scans. I think the main consideration what we thought was infection, bacterial or fungal, but I think Dr. Vivek also raised the concern of whether it can be HLH. These are the typical examples which we see of HLH in terms of imaging. I'm not sure if it's on the earlier onset, we we may not pick up these findings, but the posterior fossa abnormalities, these inflammatory changes, the nodular enhancing foci is more typical of an HLH. I found some case with these multifocal abnormalities, punctate abnormalities in the deep brain nuclei with microhemorrhagic foci. Subdural collections and meningeal inflammation, I'm not sure is typical for HLH, at least not come across any case. And I think one more possibility of toxoplasma was raised. Again, meningeal abnormalities and subdurals slightly atypical for toxoplasmosis. So, Dr. Vik, I'm thinking infection, maybe fungal, given the chronicity of the infection, and I'm not sure of the HLH, if it is still a possibility or not.
Subdurals, they are not empymas, right? Because there's no
No, they are not
restriction.
empymas, and there is no, I mean, the inner membrane does not enhance.
They don't need to be drained.
Yeah. And there's volume loss. It can be secondary to the atrophy also.
Yeah.
If you see the caudate also is atrophied, the frontal horns are prominent. So,
can it just be a sequelae, everything, or there is an active illness still?
I would say sequelae.
All of this could be just a sequelae, rather than active illness is still being there.
Yeah.
Right. So maybe if a second CSF now shows a normalization, one doesn't. Basically, these are just findings which are taking time to resolve.
Yes.
Whatever has been. Right. It's just the fever isn't settled. So fungal is still a possibility.
Yeah, fungal is still a possibility. There can be microabscesses, the ones in the deep brain nuclei, or they can be secondary vasculitic changes in ischemic abnormalities.
Right. And that secondary ischemic will be more bacterial vasculitic process. Right. So we stay on the bacterial fungal route. And Candida or Aspergillus, we cannot really, because hemorrhages are there.
Yeah, I mean, both of them are, but Candida is more, smaller lesions are more in Candida, as far as I know. Multiplicity is more in Candida, as far as I know.
Sure. Okay. Thanks.
Okay.
Yeah, Nihaal, did they check, for Listeria specifically? Because, I saw a couple of Listeria cases that you can see, microabscesses throughout the brainstem, also posterior fossa. But this case, these small peripheral enhancing lesions, maybe, representing just microabscesses, like, we see in Listeria. It's very hard, area.
So does Listeria present at 5 months? Is it related to the food you eat, food products or something like that? Listeria? It's by the contaminated food, or is it not? So 5-month-old is just breastfed.
Okay.
No, I'm not sure. Is Listeria transmitted? I need to check. Is it more contaminated food, or is it?
I think transplacental and food. I'm not sure of the.
Transplacental will be too long.
Too early.
5 months.
Yeah.
Too late. Too late.
Yeah, but we're still working on the infection side.
Right. Yeah, and especially with CSF showing neutrophilia and low sugar and high protein.
Yeah.
Which could again be fungal or bacterial.
Fungal or bacterial. Yeah.
Right. Okay. Thank you.
Venkateshwar, no angio was done. Only venogram was done. Yeah, necrotizing encephalitis. Okay.
So maybe like acute viral process leading to necrotizing, but the CSF.
But the CSF doesn't. Doesn't. And it's not a typical ANEC. For necrotizing type feature. And subdurals again, certainly not typical. So yeah, I think bacterial fungal is the prime consideration, Dr. Vik. Can go with that.
Yeah. Thank you.
Okay. I think we have one more case. This is the last case. This is the case. I think I put it up. I don't have a neurologist here, but I think it was scanned a couple of days back. This was an 8-month-old with facial dysmorphism. I'm told that this child has a depressed nasal bridge and some hypertelorism with a motor more than cognitive delay. A child also has central hypotonia and cerebral vision impairment. There are no perinatal issues for the child term gestation, born to non-consanguineous parents. I wanted to show the imaging. These are T2 axle and pair axle sequences. Again, confluent abnormalities, predominantly involving the white matter structures, more frontal dominant. You have some cystic changes in the bilateral basal ganglia, anterior basal ganglia, especially the left basal ganglia, the periventricular regions out there, the antiperiventricular regions. Coming down, also you can see the temporal and occipital white matter has abnormalities for 8-month-old. Posterior fossa, again, there is some delayed myelination in the cerebellar white matter. On the flare sequences, you have some refractory changes in the frontal lobes. You can appreciate the cystic abnormalities in the periventricular regions and the left anterior basal ganglia. I could not appreciate any structural malformations on the sequences. And on the SWA sequences, you have these areas of punctate calcification in the center of semiovale, the coronary aorta, the periventricular regions, the anterior basal ganglia structures. We have a corresponding CT, which was done a day prior, I think a month prior, and you can appreciate the calcific changes in the predominantly the central regions of the brain, basal ganglia, and the periventricular and deep white matter structures. On the SAT sequence, you have thinning of the corpus callosum and also some atrophy of the brainstem. If you're looking for imaging, I think we thought of the white matter abnormalities with calcifications. To think of the interferon-related disorders, CMV, and also possibility of cocaine syndrome are considered. We thought of interferonopathies as one of the prime considerations, given that the anterior predominant white matter changes, the central calcifications. The child did not have any other skin lesions. We had just specifically asked for any chilblain type lesions. At this point of time, the child did not have any lesions, skin lesions. The other differentials, CMV, cocaine, and Col4A12 mutation. After the CT, a torch profile was done, and the torch profile was at least the IgGs were negative for torch infections. So we are going through the possibility of interferon-related disorders as the prime consideration, and wanted to check with the panelists and the attendees if they have any, they agree with it or have any alternate possibilities. The child has been sent for whole exome sequencing. Scan was only 2 days back, so we don't have a definitive answer. And the cystic changes, I think, are chronic small vessel ischemic abnormalities, which again might support the possibility of interferon-related disorder.
So, would you consider mineralizing microangiopathy or?
But white matter changes are not typical. Yeah, that was the one thing. And I think 8 months maybe slightly too early for meningio. Usually around 2 years or 3 years, if I'm not mistaken. But yeah, the white matter changes are not typically seen. That was. Okay. All right. I'll give you a feedback on the genetics once it comes back. Given that the torch is negative at this point, and there's no structural malformation, temporal lobes which are commonly seen in CMV, so not seen in our case. So we were thinking of genetics, and once we get the result, I'll get back to you. Okay, so that's our last case. We'll meet again in 2 weeks' time. Kindly submit your cases by the 24th of September. You can email me or post on the WhatsApp group. So till next time, see you and have a good night.